Great, maybe we should get started since we're right at 1:05. I wanted to thank everyone for making a drive here to UW. Hopefully it wasn't too hard to find and parking was okay. I think what we'll do maybe is start with an introduction of folks here in the room. Just wanted to give you a little bit of a tip on our microphones that are around here. If it's green, that means we're live. And you just push a button, looks like this on there, if you wanted to mute, and then it'll go red. So right now, I think we're not getting any feedback or anything like that, but just know that's how they're live. And then we'll go to the phones and the video and see who's joining us that way. Representative Schmick, do you want to start us off?
Sure, Representative Schmick, 9th District. I'm the ranking member on healthcare in the House.
Good afternoon, Denny Lord, Telehealth Program Coordinator from Providence.
Joelle Patti, Nurse Practitioner at Swedish Health Services in Providence. I run a telehealth program as well as some other clinical programs.
Priscilla McGraw, Administrative Assistant.
John Scott, Medical Director for Telehealth at University of Washington.
Cara Towell, University of Washington, Department of Psychiatry.
And Cheryl Kuchala, Premier Blue Cross.
Great, thanks. I think what we'll do, when we have a time for a public comment, we will ask people to introduce themselves. But let's go to the phone and video. Is there anyone who's joining us by phone and video and wants to introduce themselves?
Mark Lowe, Medical Director, Seattle Children's Telehealth.
Great, thanks, Mark. I just want to make sure everyone knows this is not Mark Del Caro, who had been previously joining. We're going to get to that later on our agenda, but Mark Lowe at Seattle Children's is joining us. Yeah, who else is on the phone or on video?
Lori Wakashige from Legacy Health.
Thanks, Lori, for joining today. Anyone else?
Susan Stern, UW Medicine, but Washington American College of Emergency Physicians.
Hi, Dr. Stern. Thanks for joining. Other people?
Sandy Kukla with GCI.
Hi, Sandy. Was it Sandy? Did I get that right? Okay.
That's right.
Great, thanks.
Leslie Emmerich, Washington State Hospice and Palliative Care Organization and the Home Care Association of Washington.
Hi, Leslie.
Hi.
Hi, it's Melissa Johnson representing the Washington State Nurses Association and the Physical Therapy Association of Washington.
Okay, thanks, Leslie. Other people who are on the collaborative who want to introduce themselves? I especially want to see if Adam Romney is joining by phone. Adam, I know was going to do a brief update. Adam, are you on phone or by video? Oh, okay. Okay. I just learned that Adam was in a car accident this morning, so we do have a backup for him though. So we have that. Scott Kennedy, we have you. Okay, Julie Sylvester. I don't think Julie Stroud's going to be joining us, but let's see if Julie Stroud might be joining. And Ricardo Jimenez, Chris Cable, or Brody Jachenko. I know Sheila's out of town. Okay, maybe it was, and of course, Senator Becker, I think, is attending to a very important business down in Olympia. And I think, Representative Schmick, do you know if any of your other colleagues were planning to join us today?
Well, I think there was some question about, as of yesterday, Senator Becker didn't even know we were meeting.
Oh, dear. Okay.
So
okay.
She does know. Yelm Highway was closed because of trees as of this morning still. So I don't know, she may not be able to get away from her home.
Okay, all right, thanks for that update. I had talked to our staff here, and they communicated with her last week, and she didn't think she was going to go make it. So, okay, well, great. I think what we're going to do first is to review the minutes from last time, which was held at Molina in Bothell. So I'm just going to kind of scan through here and just highlight what we talked about. We spent about half the time talking about e-consult. It was kind of a follow-up of our time down in Olympia in January. Just some updates that both Chris Cable and myself talked about. I do want to maybe update people on the last action item, which was Chris and I were going to talk offline about developing some guidelines. And I have talked to Cheryl. Cheryl and I had a meeting, as well as I talked to Dr. Guff about this. And I think kind of offline, we had decided probably the best next course of action was to have the healthcare authority to really help us develop those guidelines. I think we're all kind of looking for them to develop some policies. So I have not followed up with Chris on that for that reason, if folks are okay with that. I think that's going to probably be more helpful for the greater good. Any issues or concerns with that? Hopefully that's clear why we took that course of action. And then let's see if there's some others. There were some requests for feedback on the FAQs, and we're going to get to that next. And Sheila had given me some offline feedback. So, hey, Brody, it's good to see you. So a lot of this was about our e-consult stuff. And then let's see here. Fraud prevention was really kind of standard stuff that had was a presentation by Sheila Green-Shook. And it was really some of the broader guidelines out there. So we have the FAQ documents, which we'll finalize hopefully later today. I think that was about it. See if there's any edits or comments about the minutes from last time. Anything that was incorrect that people wanted to change? Well, good. Okay. If I don't see any strong opinions against it, we'll submit those for the public to review, and we'll go on to our next agenda item. And that's to go over the frequently asked questions. So these are documents that we are hoping to share with the public, and one is geared towards providers. The other one is geared towards patients. So I'm going to pull those up. Maybe I'll go to the one for patients first here. And you all should have that printed out in front of you to review. Here. So the first thing I want to make sure everyone knows is that we did format everything in the same formats, the same font, spacing. Thanks for doing that. And let me share my screen again. Okay, so hopefully people can see that. I'm going to blow up that font. It's a little hard to see. So just to go through the first question, which is, what is telemedicine? And we said that telemedicine is a remote delivery of healthcare services and clinical information using telecommunications technology. This includes a wide array of clinical services using internet, wireless, satellite, and telephone media. I think we may have pulled this from the ATA website, Denny. It kind of sounds like a very ATA kind of document. So this is not anything that we've really made up. It's just pretty standardized, accepted definition. Any edits on that that people think is not clear? This is a patient who's reading this.
Can I suggest that maybe underneath the title we put a patient's guide or something to distinguish it from the other?
Thanks. As we are reading this, I've always been trying to have things that are available for patients to be on a sixth to eighth grade reading level. So if people can help me keep their eyes out for maybe big words, or we can maybe put them less big words. And I don't know. Well, that's a long one, but yeah. So let's just read through this with an eye towards a 6th grade reader, for those of you who have 6th graders. So what is the distinction between telemedicine and telehealth? And so what we're trying to really say is that telemedicine is more clinical and telehealth is a broader kind of definition and includes education, public health, and health administration. And then the next statement is really that in practical use, we tend to use those pretty interchangeably. But if you're going to be kind of a stickler for details, there are some subtle differences there.
There's one typo in there.
Where is it?
Broader term that encompasses instead of than encompasses.
So focused on aspects of care. Which line?
The second line.
That right there.
Yeah.
Thank you. Okay. Thank you.
Mhm.
Any big words we can get rid of? Yes. Or replace? Not seeing any. Okay.
That's good.
Any comments or questions on that? Okay, so the next.
I have a question under the can clinicians get paid for delivering telemedicine?
Yep.
Maybe it might be, as a patient, can I use telemedicine?
Where is that?
It's on the other.
This,
Okay. Can we? Yeah, we're on the one that's for patients. Can we just
okay, I'm sorry.
put it as a parking lot issue? And
I was on the wrong.
they start out the same, so they look a lot.
That's
You're a
why
fast
you need
reader.
the patient's guide.
Yep, and we got it. So we're the number 3 question is how typical is telemedicine? You see that one, Representative Schmidt? I mean, is this a helpful question for the average patient? I mean, do you think they're asking that? I don't know.
I think a lot of detail.
Yeah.
I like it because it creates the sense that it's an accepted modality of care delivery, but we could probably reduce it a bit.
Mhm.
Okay.
I wonder if we could start it with the halfway through where it says over half of all U.S. hospitals. So I can see them being interested in knowing
Yeah.
how
yeah.
available it is to them.
Or maybe even taking out the second and third sentences. I'm going to highlight the ones I think maybe could go. Because that's just a lot of statistics, and I don't know if that. I agree with people that this is a little bit long.
Maybe you need a line in there saying that this is an effort to help consumers receive care. To start off with that premise, rather than telemedicine is a significant, rapidly growing. What's the real purpose of it is for them, patients, to be able to access care. I'm just suggesting.
That's the purpose.
This is Sue. Can I suggest something?
Yes, Sue.
Sorry. I think what you just said about the purpose is a really good idea. And I would put that up, like, what is telemedicine? And then I'd put another section, what is purpose? And then it would go right down into all of this. So right away, people understand what it is.
Okay. All right, I'm gonna type it up, but while it's still fresh in my brain, the purpose of telemedicine is to improve access to, do we say specialty care or just care in general?
I would say care in general.
I think care in general.
Yeah, to healthcare. So I'm gonna take that right there. I'm gonna delete that. And you know what? I think I agree with Dr. Stern and Representative Schmidt. Maybe we put that first. What is the purpose?
You're making the assumption here that people know what this is.
Should we put a second then?
No, I'm just
Okay.
I'm just commenting. We all understand what it is and what we're trying to achieve. If you asked a person on the street if they know that, I would question whether they would know that.
Maybe we'll put it second then.
That's a good spot.
In many ways, I mean, to define a term, you need to show what its purpose is. So whether it's 2 questions or the purpose is defined in the first question. Either way it would work.
I kind of favor very short sections that people can kind of just walk through it. It's kind of just been my style.
Dr. Scott, this is Lori Wakashige. Just a clarifying question. So the document is intended to be on the website for anybody who wants to provide the patient with more information. Is that right?
That's right.
Okay.
Yeah, this would be, you know, if you say you were a small small practice, I'd say this is public domain, and you could give this to a patient. And it's also for people who just want to learn a little bit more about it, whether it's the media or just the patient who's trying to see if this is the right way to get healthcare for them.
Okay, thanks.
I do think we need to flesh out that answer a little bit. I mean, the response is fairly vague. There's many things that improve access. I mean, specifically how, like, I don't know the exact wording, but it's really about improving access specifically by providing more options or choices on how to have a visit with your doctor or healthcare professional through, you know, I guess all these other things. I'm not sure exactly what, but
Would you list it as such as, and list a few examples that people might recognize?
Such as is probably the question above, right?
So maybe we could say by offering another alternative to access care
Through technology.
by phone or internet or something.
Yeah.
You get all that, Dr. Scott?
Well, I'm just trying to summarize it by offering an alternative way of
delivering,
communicating,
accessing
care with a provider. I was trying to pick up on maybe I think it was your idea, Representative Schmidt, of giving examples. You know,
well, such as.
Examples.
People may read this and they say, okay, what does it really mean?
So maybe 3 examples in there.
Yeah. What would be some kind of?
I can help you with that later.
Oh yeah. Okay.
Yeah, sure.
I would think an example would be kind of like a mental health. A mental health. That's it.
Accessing by smartphone. Just thinking about
online urgent care access.
I mean, it could even be things like bronchitis or sore throats.
My child is sick.
Right.
I don't know what to do. I mean, do I need to go to a care facility? Do I not? These, you know.
Was the main, to build on that, is the main differentiator of telemedicine essentially a convenience factor rather than focusing on the types of things that could be delivered, because you could go to urgent care, you could go, those are also, but just focusing more on adding more convenient options on how to actually visit with your doctor is really the purpose.
And increased access.
And increased access, yeah. And you could talk about the purposes. There are people who live in more remote areas with less access to a wide variety of specialties that would benefit them. The convenience factor would be even people who are traveling or are sick at home with a family and can't pack everyone out. They can just make real practical examples as opposed to the how, but the why. That may be more what we're trying to think about here.
I was also thinking, I mean, some of the examples we've mentioned are more outpatient-based stuff, and I would like to throw in some inpatient examples like telestroke.
Stroke, yeah.
Or
time-sensitive emergencies. That aren't available in rural communities, sort of thing.
Time.
But in this modem, if you're going to access care with a phone, telestroke is more done in, as I understand, in the emergency room or in those settings where the doctor's, ready to go. Because the EMTs have said possible, heart attack, where they're connected, ready to go when that person gets into the room. They're ready to go.
That's right.
Is that something you want here? Because, I mean, you're not going to access that on your phone, I don't believe.
Well,
Consumer would be
mobile,
requesting.
mobile health via a smartphone is one modality of delivering care, but you're right, that's more outpatient-based versus inpatient.
The only thing that I'm trying to, if I'm the consumer and I read this, I would like to read this and have some partial understanding of what I can do and what's available to me. What's the intent of it? That's
So how about the online urgent care, the hospital-based emergent stroke scenario, and then maybe a store and forward dermatology or something?
Okay. Or
I don't know if you want to do those now.
be taking a picture of a skin lesion. Dermatologist. What do people think what I've written? I'm just going to read it for folks who maybe don't have video access or just on the phone. We're struggling with a second paragraph. It was, what is the purpose of telemedicine? This is after the section we talk about a definition of it. So here it goes. The purpose of telemedicine is to improve access to healthcare by offering an alternative way of communicating with the provider. Examples of telemedicine include a Skype-like visit for mental health care, evaluation via video visit for a sick child, or taking a picture of a skin lesion and having a dermatologist evaluate it. Is that? I mean, I don't know about if we put Skype in there. I mean, maybe it's endorsing a certain platform, but people understand. I mean, I'm just thinking about how do I explain this to my mom and dad?
Yeah.
And,
chat.
Or could you say video or
Video chat,
telephonic? Because it could be either.
Or I mean, if some people said smartphone,
We've used video conferencing.
video conferencing. Okay.
I don't know if that's helped a little bit or not, but.
Yeah, video chat like
Yeah,
Does that get exhausting?
Yeah.
Sue, go ahead.
I like the term video conferencing. It's agnostic to any type of technology or company. I guess the other thing is you can't be specific, but being specific is really hard because it's so broad. It does include the emergency department. It also includes virtual clinic. It includes and it's changing, and we would anticipate that it's going to change over the next couple of years. So
Then maybe
couldn't you say improves access to care somehow I guess what I'm going to say is probably dumb because it doesn't say anything, in a broad range of settings, from patients who are already in the hospital to those who are at home. I don't know. I mean, as we try to get specific, I don't know, I guess I worry that's...
you say it takes place in a variety of healthcare settings, including hospitals, clinics, nursing homes, etc.
Yeah, that would be great.
You want to say that again, Danny?
Oh, I'm good.
These visits can take place in a variety of clinical settings, including hospitals, clinics, nursing homes, patient homes.
Hospitals, clinics, homes, and nursing facilities.
I think that's a good sentence, but I think it belongs to the first question. That's more what it is rather than what's the purpose.
Yeah.
Yep.
So I do like Representative Schmick's comment that at the end of the day, when someone reads this, they want to understand why it matters to them and what they control. And so if you give too many examples of things that happen in the hospital, I mean, those are all true. Okay, well, when I go to the hospital, I expect the hospital to take care of everything. Well, these examples are things that they can actually initiate, and they themselves can actually request, the telemedicine service. So in some ways, I like the examples, keeping it simple and things that they themselves can initiate.
But I think getting back to Sue Stern's point about making sure people know that these are just several examples and that.
Well, could you put a sentence right after that and say these are just some examples and this is a growing, ever-evolving field or something to that effect?
Telemedicine is a growing,
et cetera, right there.
evolving field, and the types of conditions and settings is is it growing really?
Inclusion.
Is evolving. Okay. It seems like this would be a good opportunity to maybe put a link, a web link to the ATA or something like that, or if people wanted to, they could click on it and learn more.
I'm wondering if in the first sentence, when we're talking about communicating with, we say receiving care from?
Yep.
Yeah.
And I'll try to receiving care.
Just make a comment. Yeah. I'm Sean Ackerman, Chief Medical Officer at our group, managed care. So when we kickstarted our telemedicine program, we found it's very helpful for patients who have no idea what it is to have a little video link, something mentioned. It's a very quick 15 seconds about a few examples. If you go to ATA, a lot of the vendors are doing this, as well as a lot of the private companies. You go to their website, the first thing is a quick link to the video. It captures everything like within a few seconds. And because it's so broad, it's really hard to put into an actual sentence. So, I mean, the general scope of what the program is, and then I feel like patients will really understand it with that video.
Yeah. Is your web link generic, or is it specific to AmeriGroup?
We have a contract vendor that we use is to that particular vendor that they made. But there's a lot of examples out there. I don't know, like.
I just want something that's non-trademarked or more in the public use. Do you know? I'm hoping there's something from ATA or NRPRC.
There's a good one there. Yeah.
Who's that, Danny?
There's a good one. I think it's ATA that has it.
Okay.
I'll send it to you.
So I'm going to put a little thing here, web link to video from ATA. I think it's a great idea, Sean. Thanks for trying that. Francis, when you were at Karina, did you ever have to do kind of a little bit of education on like what to expect and things like that? Are you having?
I think that someone's already mentioned this, that when you put in an example, that becomes the list.
Yep.
And so it's really that distinction between, that's why the video is great, because you can, it's broad. They can conceptualize. So I think that was one. I think a lot of it was in the verbiage. A lot of it was in trying to really be careful about how the sign-in went. So when patients were going to the site, that they could kind of get walked through the scenarios in which was appropriate, when it's not, and always call out when it's not.
Yeah.
So that they can differentiate. There's also, I think most sites now do have, if you have any of these symptoms, you're immediately excluded. So you start to begin to parse it out and differentiate. But the messaging is difficult. Sometimes it's kind of going through the process that's most helpful for patients.
It's a challenge with so much generic document like this to what you can't see. So I'll tell you what, maybe Denny and we can take a look at the web link and try to come up with something that's generic. Is there a comment?
Hi, my name's Anne Ahern. I'm the general counsel at Karina right now. So I saw you the other day. Anyhow, one of the things that we do, and kind of talking about what Dr. Bob was, is we do like an emergency check at the beginning of any intake for a patient coming in, and it goes through the list of what is not appropriate for telemedicine. So kind of in defining what telemedicine is and what the purpose is, it could be helpful to say also what it is not appropriate for.
No. I think that's good, except for there might be some people out there who are using it for tele-ED, and which is exactly what you want. I'm struggling with like how specific we get here.
And this covers all models. It's not just direct to consumer, but it's also originating sites of facilities. So it becomes a more, it's a broader perspective, which makes it that much more difficult. I do like, I think the videos are really
Okay.
good. A good
Seeing is believing.
resource and it's gonna be adapted to it, I think.
We were talking about what is telehealth, and I pulled up our document that we use at Swedish, the FAQ that we send to patients, and this is a nice way to think about it as well, which are what are the advantages of video consultations. And so our section there is very brief, but it says every patient situation is different, but in general, the benefits of the service are better access to specialist care, reduced wait time to see your specialist, reduced travel time and cost, and reduced absence from work. So it kind of conceptually lays out sort of, I guess, rationale in broader strokes.
Okay, I like that. I think that brings it home, brings it back to, okay, oh, this is not just kind of space age, it can actually really save me time and money and help my employer. Okay.
No matter what modality you're utilizing.
I think maybe that goes up to, what is the purpose, right? They put right here. Every situation is different. However, patients have reported benefits such as reduced wait time, reduced help time, reduced time away from work. You don't even need that. Every situation is different. I can just go straight to that.
Can you take out the second and third reduced?
Yeah. Yes, a lot of reducing. Okay. Okay. So then I think we're back to how typical is telemedicine, and we opted to cut this down a little bit. And I should just say that the document we were working from was actually almost verbatim from the ATA. So I think it's good to customize it to what we think Washington State patients are thinking about. I think this is helpful over half of all U.S. hospitals. Is there any way we could do this for Washington State? We have a sense for. Great if we can go.
It's even more.
Do you think we could say that?
The majority.
Over half of Washington hospitals offer?
I have 6 critical access hospitals of some of the smallest in the state. Every single one of them uses telemedicine in one form or another.
I'd say the majority of Washington.
I think saying over half of Washington hospitals. That's probably people feel like this is a safe document or safe statement to say there. Over half of all Washington hospitals now use some form of telemedicine. I don't think there's any kind of verifiable statistic that we could look this up. But.
Well, I don't think we want to limit it just to hospitals either for a stat. Because hospitals are not the only place that offer telemedicine, so
payers.
But if you say that, does it give it? They're all using it. Like it gives a sense of reassurance that the hospitals are using this too.
Yeah, no, I'm not saying to strike at hospitals, but I don't want people to think that the only place you can get telemedicine is hospitals. So.
Can we say like, and some clinics or some?
And many clinics?
Sure.
I'm just trying to think of ways that will solidify this. My constituents are older. That I have a lot of them that live in those rural, remote areas, and I'm just trying to think how they're going to think about this, and that if hospitals and clinics are using this, that's a matter of reassurance.
Yeah.
This is safe. This is effective.
Yeah.
couldn't speak to the age specific demographic that you're referring to, but as a benefit structure, there's so many self-insured corporations that have adopted telehealth as a benefit for their employees. Again, just to lend some credibility to what's happened in a broader, basis community-wide, and there is some data around that.
Okay. Great. So I'm going to ask you just present the screen so people can hear your comments. Yeah. And Francis was just saying that maybe we add something about the payers. Is that what you're saying?
Well, I'm talking about just the corporation, so the self-insured markets, and it would lend validity. I think there's a comment around the percentage of CEOs who are committed to bringing it into their benefit structure, and I think that maybe something like that might help. I'll see what I can find.
Yeah, I've seen that before. I think it's
Yeah.
like U.S. corporations now offer the telemedicine as a standard benefit in health insurance.
So the sentence just above that, I don't know if it's in the right, I don't know if it belongs in this section, I guess, about.
It's more about mobile health, right?
Mm-hmm.
Yeah. What's your concern there, Sherry? Just because it
Because we're
so
talking
much.
about how typical telehealth is, but then we're talking about downloading it to cell phones. I just don't, it doesn't feel like it's quite in the right place.
Mm-hmm.
I think it does give it, I mean, if it needs to be reworded, that's one thing, but it does give a sense that
It's easy to use.
you can act, I mean, a lot of people are downloading telehealth apps on their phones, so it's typical from that perspective.
So, Brody, would you say many patients and physicians are using applications as part of the telemedicine on their smartphones? Or
Maybe that, yeah. I think I like that better.
Yeah. What's interesting about the answer, even though it's a really short answer, when we were talking about typical, the first part is about who's supplying it. The second one is how they're getting it, and the last one is who is offering it. So it's we're trying to make 3 different angles to answer the same question: how typical it is.
do you think we can answer that in this? Those three parties. I mean, I think that last sentence kind of gets at the corporations.
Yeah.
Mm-hmm. But let me get back to patients and physicians. Download health wellness applications to assist in telemedicine. Right, so we're working on this paragraph, how typical is telemedicine? Again, for folks who are on the phone, I'm going to read it for you. Over half of all Washington hospitals and many clinics now use some form of telemedicine. Around the world, millions of patients use telemedicine to monitor their vital signs, remain healthy, and out of hospitals and emergency rooms. Patients and physicians can download health and wellness applications for use on their cell phones to assist in telemedicine. Over half of U.S. corporations now offer telemedicine as a standard benefit in their health insurance program.
I don't know if the world one is needed, but
Yeah.
it's fine.
I think
Or you could start broad and then narrow to Washington State.
Yeah, there you go.
I say around the world, all of these are options.
It's not so much around the world, Brody, that I like in that sense. It's just about monitoring vital signs, remaining healthy, keep staying out of the hospital. And that's what I like in that sense. You could even say millions of patients use telemedicine. Just take out around the world.
No, I don't have an issue with that either. It's just.
Hello, this is Leslie Emmerich. I just had a quick comment. Did you say patients and physicians? Because if you specified physicians, it'd probably be better to make it provider neutral, so ARMPs and others could be included.
Thank you, Leslie. I've changed that. So now it reads patients and providers. Or we could say patients and
Thank you.
Yeah.
So can we clarify U.S. corporations? I'm just,
Employers?
well, just thinking again about the audience. They may or may not really know what that means. You know, are we talking about insurers, you know, payers? So we say employers, and they include it, but when it kind of distills down at the end of the day, it's still the payers who are covering the benefit, right? That the employers.
Or the TPA. So like a Microsoft, for example, would have a benefit, you know, for their employees.
You mean
A
on site?
standard. Well, a telehealth, a direct-to-consumer model. So they would just be able to call into a telemedicine provider entity that would provide, you know, telehealth services to on demand, for example. A number are doing that.
Joel, I
Or
don't,
different limitations.
well, I don't know if it's helpful, but there is a section on the second page about Medicare and Medicaid paying for these.
I think.
And then also private health insurance plans, we kind of get that down below.
I like the idea of many employers rather than corporations. Corporations
Mhm.
don't have a real positive
Yeah, that's
reputation, and it's growing with their people not trusting.
Yes. How about this? Many employers now offer telemedicine. Okay. And just a recognition that we start diving into more of the specifics about coverage on the second page here. So we'll get to that. Oops. Okay. So the next question, if we're okay with that, are we okay with this paragraph? Any last comments or suggestions on that? Okay. So the next question is telemedicine safe? This might get a little technical and wordy. I think the first things we say is yes, telemedicine is safe. It's guided by technical standards and clinical practice guidelines and lots of research. I don't think, I need to put this American Telemedicine Association. Has produced a series of standards, guidelines,
and best practices.
Hi, this is Leslie Emmerich again. I just wanted to say, where would it be appropriate to insert HIPAA compliant so that personal patient information is protected?
Yeah, we actually have on our FAQ, how private is the video consultation? And I thought we could put, you know, something about confidentiality and privacy. Ours is just a one-sentence statement that says the same privacy and confidentiality requirements that apply to a face-to-face consultation apply to video consultations. Now, obviously, we've addressed what is home and, you know, sort of if people are on a mobile phone, then they're making choices about what their privacy looks like on their end. So we could probably put a caveat in there about that, but
Yeah, I would build on that, and I'm not sure there's any value to the consumer knowing that the ATA has these guidelines. They've probably never heard of them, but replacing that just with that both the privacy is held to the highest standards as well as, you know, even from a clinical perspective, providers are held to the same quality standards as whether they were face-to-face or through telemedicine, I think would be more impactful to the consumer.
And then in most settings, the audio video conferencing is encrypted to ensure, you know, confidentiality. So it might be worth seeing that.
So let me just read what I wrote. Clinicians are held to the same standard of care through a telemedicine visit as an in-person visit. I think we say similarly. Similarly, the same standards for privacy for an in-person visit also apply to telemedicine visits. Does that sound okay?
Mm-hmm.
No,
I'm not a lawyer, but I worry a little bit about answering a blanket statement, yes, telemedicine is safe. Because, I mean, are there situations where it might not be safe? And are we then, you know what I mean? Could we just take the yes out of there and just, and then in terms of the 6th to 8th grade reading level, maybe the second sentence, instead of saying, yes, guided by the, you could just say, telemedicine is a safe and cost-effective way to extend the delivery of healthcare, it is guided by, or something like that.
Like
Am I being
But
paranoid?
the accused are saying is that it's not, they specifically say it's not for emergency uses, they actually call out patients that it's not for all, maybe I highlight that, it's not for all medical uses.
Right.
So it's certain situations. Call it word around that it's only for certain clinical minor.
I can't hear what you're saying. Sorry.
What I was saying is that if you're reading a lot of the language in the new platforms that are coming out on their FAQs, they're indicating that very clearly it's not indicated for a lot of for specific conditions. So to make a blank statement, I think we do have to be careful that it's safe for all cases. And they specifically say that it's not for heart attacks, strokes, or, you know, depending on what I mean, again, we're talking about a very broad sort of use of telemedicine. It could be safe for a telestroke, but not for outpatient, right? So we just have to word it that it's probably have to be guided by the provider and certain conditions are okay to be used.
One way to say that
I think
yes, when clinically appropriate, something like that.
so. I have two.
Go ahead, Sue.
So I think that's really good, and I have two questions. First, maybe in the top where you put the purpose and what to use it for, maybe you also put a disclaimer up there that says, you know, if you're having chest pain or you think you have an emergency, you still need to call 911. So that, I don't know. But under this, maybe it's not is telemedicine safe? Maybe that's not the right question. Maybe it's a question of such like, how do we monitor the quality or appropriate use of, or something like that? I don't know. Is safe the right term?
Yeah, I hear what you're saying, Sue. I'm just really trying to reassure, you know, the older constituent in Representative Schmick's district. So I'm really trying to.
Well, I'm just looking. Is the average consumer going to know when clinically? I don't have my glasses.
Yeah.
The third, does consumer know that?
Yeah, that's true.
Patient know that?
I would just take out the yes and just start with the telemedicine. Because you say telemedicine is safe and cost-effective way to, you know, it's not as blankety statement. You know?
Okay.
But you're not asking them to make a decision on whether it's clinically appropriate. You're just saying that's being taken into consideration. It's on the provider, I would assume.
Yeah.
Yeah.
Well, like depending on the situation, in most cases, it's safe. And it really is dependent on the nuances of what's occurring.
Who and how services provided.
The situation.
Again, I'm trying to get wording that somebody reads it, they're going to understand what you're saying.
I think it's safer to not try to qualify. Just start with your answer.
Well, I'm certain that if you're on the phone and your left side is numb and you're slurring your words, whoever that provider is going to say, call 911 now.
And the warnings are all there to initiate any telemedicine visit as well. So I think
mean, do we say something as obvious if the provider determines it's unsafe, they will give you, additional instruction or something? I mean,
with this. It may not be appropriate for all clinical situations, and you should, and a medical professional will help you.
Yeah.
And a medical professional can help you determine if telemedicine is appropriate. Yeah,
I think we're talking about, are the services that are being provided medically sound and safe? And then the second part of this paragraph sort of addresses a more global set of standards. So maybe that goes in a different paragraph in terms of privacy and confidentiality and standards of care. Does that make sense?
I might at least make that a separate paragraph here, so there's two different ideas. Let me just read this one more time for folks. Is telemedicine safe? Telemedicine is a safe and cost-effective way to extend the delivery of healthcare. It may not be appropriate for all clinical situations, and a medical professional can help you determine if telemedicine is appropriate. And this is where we start to kind of shift a little bit. The practice of telemedicine is guided by technical standards, clinical practice guidelines, and backed by decades of research and demonstration. Maybe we make that a second paragraph. What do you think, Joelle? Like that?
Definitely. I don't know if we need all of that. I mean, when I think of my sixth grader reading it, they're going to get lost in the decades of research and demonstrations. And so I understand the spirit of it, which is, this isn't just a fly-by-night kind of fancy thing that we just drew up. This is something that's been going on for a long time. And there's, obviously there's evidence to support it, but I don't know if it's necessary. Or we could make a much more simple statement.
Could we say the practice of telemedicine is backed by decades of research and demonstrations?
But again, I don't know if my sixth grader or even my seventh grader, I've got some of those at home right now. Maybe my eighth grader would, but.
And take out the technical standards of clinical practice guidelines?
I mean, the audience is not sixth and seventh graders. It's adults at the sixth and seventh grade reading level. So I know your sixth and seventh grader could care less about decades of research, but would someone who actually is seeking this care actually be comforted that there's been decades of research?
Or maybe we take out and demonstrations, just decades of research.
Guidelines exist to maximize safety. How's that?
Does research and guidelines, does that mean that care has been delivered? You understand what I read that and there's research and guidelines, but has care actually been, care has been delivered by this method for a long time. I'm just thinking, if I'm reading that, am I going to associate that care has been delivered through this modem?
For a long period of time, and that those research and the guidelines have been supporting it for a long time.
You understand what I'm asking?
Okay, so how would you say that?
Well, we do kind of address in some of the earlier questions about how easy it is to set access, and there's plenty of examples. I don't know if we necessarily have those together.
Is your question more have they been doing telehealth for a long time, or just that they've been researching it for a long time?
There's a difference. I view it as there's a difference between delivering care and research and guidelines.
Yeah.
That's all I'm trying to
I'm not saying that
communicate.
research has been able to demonstrate or prove that telemedicine can be delivered in a safe and effective way.
I like that.
I like that.
Or decades of
Decades of
research has
research.
demonstrated.
Centuries of research.
All around the world.
Can everyone see that? Do you want me? I can make the font bigger. Yeah. All right, I'll go back to percent. What I can do. Let's make this one a little bigger.
So in terms of guidelines exist to maximize safety, what about guidelines exist to ensure safety?
Can you say safety and quality?
There you go.
As well as protect privacy, and then you could get rid of that other sentence.
Yeah, then we start segueing into that stuff that we've got in our FAQ about confidentiality. I can pull this document back up. How private is the video consultations? The same privacy and confidentiality requirements that apply to face-to-face consultations apply to video consultations. So maybe in most settings, standards of confidentiality are upheld.
Similarly, the same standards for privacy and confidentiality. It seems to be the same sentence.
Same standards of care. Your sentences are shorter, and you want to have like one idea in each sentence. That's what I'm trying to, you want to pull this shorter. So I think we're getting there.
It's good.
Yeah. Joel, you okay if we have this as 2 paragraphs?
Oh, totally, yeah.
All right.
Whatever makes it easiest to read. I don't know if we threw in the encryption bit and if it's necessary, but I think when people are thinking about these things, that might sort of bolster the sense of, you know, this is part of the safety element, is that someone's not going to hack into the video or be able to externally listen or, and I know for most telehealth settings, that's what we're aiming for.
Right.
And it's a standard of care and quality, really.
Yeah, I don't know how specific we need to get that privacy. What do you guys think? We need to have another sentence about encryption.
Or if it's at the ATA, I'm not familiar with that link, but maybe if someone's going to take the time to research it further.
I don't think that the consumer, if you say that your quality and you have confidentiality, I don't know if you need the data encryption.
Yeah.
Yeah, I don't think so either. That's my gut for it. This next paragraph, I kind of wonder if we need. It's about what's the relationship between telemedicine and health information technology. Again, this is from our original documents from the ATA. I think it kind of confuses things, and I would.
Yeah.
Okay, a lot of head nodding on that. Okay, make it shorter.
Providers would care about that.
Yeah.
I barely understand.
All right. Where can patients get access to telemedicine services? Ask their doctor, hospital, healthcare provider about telemedicine services that may be available.
What about carriers?
Carriers, yeah.
Well, I mean,
Employers.
they're going to be part of.
I actually would say we should probably say employer here. Carrier, is carrier the right term? Brody, do you like it?
Say health plan.
Health
Health plan.
Health plan, hospital. There we go. Second sentence, I don't know if we want to go to home monitoring because that's not currently being paid for. It's too specific and it's not necessarily paid for. So I might just say they might have an existing telemedicine service. Doesn't Primera have something, a relationship with one of the telemedicine providers? Sure.
Mm-hmm.
Yeah. So basic telehealth services. Okay. And this is where we start getting into the specifics of Medicare. And about Medicare Advantage. I didn't get into all the specifics of Medicare, that they need to be in a rural area and all that. I didn't know if that was going to be appropriate for this. I just said in certain circumstances. And then Medicaid, I just kind of went into what was in the bill.
Do people understand the difference between Medicare and Medicaid? I would say, on average, no.
Really?
Yes.
Unless they're covered by, I mean, if they know they have a Medicaid plan, they're going to zoom right to Medicaid probably.
But I'm saying, by having Medicare in there, does that confuse the issue? Because
Medicare, the telemedicine coverage is so different from Medicare that I felt like we had to call it out.
Okay.
So one thing we could do is maybe we could put parentheses Medicare the plan for over 65. That's the potential.
But you don't have to be 65
Right,
to
I
be
know.
covered with Medicare.
I guess my question would be, as a consumer, how would I be directed to find out how I can access it? Is it through my provider? My hospital? Is it?
I guess I'm looking for some clarity because think about who are your Medicare and Medicaid people. Are they going to be, when they read this, will they understand it?
You mean about payment?
The whole issue about coverage? Yeah, I just don't, I guess I don't want this document to be something that precludes people from utilizing it because I don't understand it.
Yeah.
That's my overall comment.
Right. You don't want to make it too complicated, but then you don't want to
not clarify.
Yeah, or just mislead them. That's the word. Okay. Well, do you have any suggestions on how we could maybe clarify that for the reader, a Medicare or Medicaid reader?
Just say like Medicare, patients typically over 65. I don't know if you want to get into start.
Or we could parentheses it. Let's put like one of these little things. Put that at the bottom. We say Medicare typically covers those over the age of 65 years. And then dialysis patients.
Or maybe just a more generalized term, people who have who are disabled. Because that could be a 16-year-old with cerebral palsy. It could be
Anybody
a
who qualifies
26-year-old with severe
SSI.
schizophrenia.
SSI.
Analysis.
And folks who qualify for SSI.
Yeah, great.
That's great.
So then
Disabled and
I'm going to put a different thing for Medicaid. Typically covers.
It's a hashtag on a tweet. Probably want to pick a different.
I know. I just did it from my I'll probably use a different kind of superscript. Help me with
Patients on government assistance typically.
State government assistance, right? It's not-
Those receiving government assistance. State. Right.
And so as long as we're going down that road, do we need to address health exchange?
Health exchanges.
And what happens with that? Yeah.
It's an animal that's more.
Right.
I'm just gonna throw out there that because there's so many different plans and variations.
Yeah.
There's just much more. I mean, I'd be a fan of just saying that Medicaid and Medicare covers based on certain conditions. Please contact your healthcare pro, because there's so many variations. You're not going to be able to cover all. It's like saying your health insurance covers a certain service. There's so many different plans that they cover different things. So even within Medicaid, it may not be so
very, very generic.
That's just my.
Yeah.
I mean, the way I describe Medicaid is those who are poor.
Right.
Or low income.
Or falling below a certain household income.
Okay. So Representative Schmidt, what do you think about having that asterisk there? Is that going to help people kind of clarify, and they'll look down below here?
I think the main thing is you're gonna have to contact your provider to see if those services are gonna be applicable.
Say provider your health plan.
Health plan.
Yeah. Because on Medicare, it keeps changing every year. I mean, that part is rapidly changing, and I think we have different rules here in our state for Medicaid.
For private insurance, the same restrictions apply as for Medicaid?
Right, it was through the law, right?
So I don't know, because it says for 2017 under Medicaid, the patient cannot be at home. That's not my understanding.
Yeah, it's actually, Medicaid covers it home right now.
Okay.
Well, I don't know about Medicaid, but I know we cover
Medicaid does.
home.
You do.
We need to.
Oh, okay. So you've been okay. So maybe we should strike that
Take
then.
that part out.
Yeah, that was.
Just say, that's generally what they cover, contact your benefits.
I'll just take that out right now.
Did you describe store and forward earlier?
Yeah.
Well,
Oh,
gosh.
Say that.
Oh my God.
Just take it out.
Okay.
They're not gonna know what that. And then I would just take out the first sentence of your private insurance.
Right here.
Yeah.
I would even take out the live face-to-face teleconferencing usually. I just say Medicaid does pay for telemedicine as long as the service is medically necessary.
Yes.
In most cases, yeah.
Are they gonna know what? I don't know if they'll know what benefits manager is.
And Sherry and Brody, we need to say anything else here? Or I'm sorry, Francis. Washington State Medicaid does pay for telemedicine as long as it's medically necessary. You need to say and meets other criteria.
Yeah, I would, because there are other criteria, but I would maybe say that, so it's not, the medical necessity is its own criteria too. So it's not what the patient feels is necessarily medically necessary, but what is the definition of medical necessity and essential covered services. So
I'm just going to throw this out there, but I mean, do we really need to get specific? Because actually some of these broad statements would really kind of cover, I mean, at the end of the day, if they really want to know if they have coverage, they should be calling their companies. And then meanwhile, we're trying to create a document that's not going to time out, where we need to be updating it. And so making a broad statement and maybe even including some information about, legislative policies continue to evolve, and there's a broader coverage for services, or, we're aiming legislative policies for broader coverage. But I mean, truth is, it really does continue to evolve.
It does every year.
Payer by payer, but also
overall policies.
right. And then there are sort of the nuances of, well, where are you located and what service do you need? I think I would just put one big broad statement for all insurances.
Contact your benefits manager.
But I mean, in the meantime, I think we're trying to create a realistic document, an informative document, but also a document that encourages people to warm up to telemedicine. I would like to think that it's going to help sort of encourage people to embrace this modality of care. So it might be helpful to say, increasingly, health plans are acknowledging and covering the breadth of services available by telehealth. Check with your health insurance company or your insurance provider.
Another part that's very controversial is if you go to Medicare, what the website, what is the definition of rural area?
Yeah.
It's very controversial. A lot of problems with that.
Yeah, that drives you crazy. I think for this to be a living document and not have to update this every 2 months, we're gonna probably have to be pretty broad and say, please just contact your benefits manager. And I agree, we should probably combine that. So let's say.
And I would say health plan, not your program benefit manager.
And I'm just gonna, that way we can just take out the Medicare and Medicaid.
Although it is important to know that it's covered under Medicare and Medicaid.
Okay.
I don't think we describe it, but just basically as a for instance, it's telemedicine services are covered under Medicaid and Medicare and privately insured programs. And then the next directive would be to talk to the appropriate person, get more information, and that could be a provider, it could be the health plan, it could be in the Medicare population, the rep, the Medicare rep that basically is sold the plan to the individual and who becomes their prime, source of contact. We don't have to be that detailed, but to contact the appropriate individuals, the point.
Representative Schmidt, you had a comment about this sentence I'm about to insert here. To find out if your insurance company covers, or if your health plan.
Health plan instead of program benefit manager.
Covers something. Please contact your, what's the right term? Benefits manager?
Yeah, I don't know that members will know.
Health plan. Because I just don't believe most people know, they don't know what a PBM is.
Or employer group.
Call the 1-800 number.
Yeah.
Okay. That's good. We're editing it down. It's always a good sign when it gets shorter, not longer. So do health plans pay for telemedicine services? Increasingly, health plans are covering the breadth of services available through telehealth. For instance, Medicare and Medicaid do cover telehealth services in certain circumstances. to find out if your health plan covers telehealth services, please contact your health plan.
I don't even think we need the second sentence. I mean, please
Well,
speak up, but I.
Francis.
Well, I think sometimes the Medicaid, they're kind of like a different demographic sometimes, and they feel like, well, is this me? I mean, they identify as being a Medicaid patient. People identified as being Medicare patient or member. So, does this apply to me? And I wouldn't go into detail, but it's just the fact that it's something they can identify with. Might be helpful.
Oops. This is the, I clicked on this. I think I clicked on that. Oh, it went down. There you go.
Do you think I'm not really sure what the right list is, but if you struck the second sentence and said to find out if your health plan covers telehealth services, please contact your health plan, Medicare or Medicaid. But you're not contacting Medicare or Medicaid, but something along those lines to include it in the list of.
You're contacting your Medicaid health plan.
Yeah, your Medicare,
or your
Medicaid, or
Medicare
commercial
plan,
health plan.
What if
I
you
don't
said,
think commercial.
what if you say
Individual
increasingly health plans, including Medicare and Medicaid, are covering?
That would work.
There you go.
Instead
That
of,
would work.
for instance.
Yeah, I like that.
Sorry.
It's good.
Oh, that went down to 2 sentences there. There's a lot of columns.
That's good.
All right, I think, and then that's the end of it. So it's 2 pages, actually a page and a half. And we'll work on getting that link out there.
Should you provide any context as to why that last picture is?
Oh, you know what? That's sorry. That was more.
Okay.
I'm gonna get rid of it.
Okay.
Yeah. This was, I think, was a left door. So.
Are we missing anything?
A definition. I got the purpose. Yep. Want to reassure people it's safe and it works.
How typical, how common is telemedicine?
Kind of back to the examples then, of which we gave a couple.
I'm sorry, Danny, right here, we were going to say a few examples.
No, I'm just saying we kind of covered it a little bit with some examples, which could get pretty broad in a video.
We were changing a word on there. Yeah.
Good.
I think that was good.
Okay, I'm going to save this. I'll send it out because we only have about half the group here. And I do want to move on to a couple of things. Is that okay if we can? We only got to one of the FAQs. I thought it was going to take 10 minutes. Oh my God, you guys are great. You guys are such detail and thinking about all the perspectives. If it's okay, I'd like to move on to the next agenda item, which is an overview of the 2017 legislative session. I had asked Adam Romney to give us a talk, but unfortunately, as you heard, he was in a car accident. But Ian Goodhue, who's head of our government relations here at University of Washington, has agreed to step in and give us an update. And I think that I particularly asked Ian to give us an overview of the interstate compact and how that can benefit our patients, and as a provider, what impact is that will be.
Thank you, Dr. Scott. Representative Schmick has probably thought he had a reprieve from seeing me after seeing me almost every day in Olympia for 4 months. So you'll correct me, sir, if I get any of this wrong, right? Okay, thank you. So I would say that when it comes to telemedicine, and actually I saw Representative Schmick this morning down in Olympia because I was there for a bill signing by the governor, where the governor signed Senator Becker's bill that adopted our definition of home. So he began his comments, as Representative Schmick knows, the governor always makes a few comments about the bill as he's about to sign it. And he made a comment of, based upon the recommendation of the Washington State Telehealth Collaborative, signing Bill 5436 into law. So we defined home more broadly, if you'll all recall, so that reimbursement can be sought for acts of telemedicine even when the patient is at home or at a location otherwise determined by the patient. And that went into effect this morning, or at least it was signed into law this morning. So that was a great achievement, I think, for this session. To turn quickly to other telemedicine related issues, we did, after a long and very substantive debate, I say we like I have a vote, of course I don't, the legislature passed the state interstate licensure compact for physicians, also passed an interstate compact for physical therapists as well in a different bill. But there was a lot of discussion. Obviously, we wanted to put safeguards in place around the state being able to have the ability to regulate and monitor the compact. Representative Marcus Riccelli in the House sponsored the House version. Senator Joe Fain sponsored a version in the Senate. It was the House version that ultimately passed. And there was there was a lot of discussion around what is the state giving up or not giving up in terms of joining the compact. And I think the argument that eventually caused the bill to be passed was that this would obviously give physicians here in our state the ability to practice across state lines with full licensure, and would have an express manner or way in which to get that licensure in another state, as opposed to the state-by-state basis or system that they have to go through now. And why is that important? I think the argument that won the day is obviously it can create care into our state and care going from our state to other states across borders, particularly our border partner states. So I know that's why Representative Riccelli sponsored it and cared about the bill. It now goes into a phase, obviously, of rulemaking, and we have to comply with the rules of the compact. I think it was also what also assuaged some concerns about what are we giving up as a state by entering it is, of course, a physician will be disciplined if there's any alleged wrongdoing by a physician in the state where the act takes place. So if care is provided to a patient or where the patient's located, so if it's one of our patients here in Washington State, that physician is going to be subject to our disciplinary rules. And if there's discipline against one of our physicians in another state, then the compact will inform us of that disciplinary action that's taken. But again, and Dr. Scott, you could probably touch on better about how this might impact some of the work that you do on a daily basis in terms of licensure. The whole idea is that there's a streamlined process for physicians to seek these licenses to practice acts of telemedicine that may go across state lines. It's going to take some implementation time. However, I think going into this session, it was either 16 or 17 states that had joined the compact. 2 others joined this legislative season. So we make it 20 total that are part of this compact where you can get express licensure.
And I think just to highlight the border states that have signed on already: Oregon, Idaho, Montana, and I think Utah.
Correct. Yeah.
Alaska is probably the only relevant state for the Northwest where this has not been signed. Danny, in your district, I think California is also signed on.
I'm not sure about California.
So can I just clarify?
Sure.
So I'm a provider, and I see a patient here in Seattle. They're from Boise.
Mm-hmm.
I do my thing, but then I want to follow them up. I need to be licensed in Idaho. I need to pay my fee, but Idaho, instead of starting the process all over again,
correct,
they will come to MCLAC here in Washington State, say, hey, this Dr. Scott, is he, who he says he
legit,
is, any disciplinary action, blah,
yep.
blah, blah. It's going to be much faster. I still need to pay the full fee for being licensed in the state of Idaho.
Correct. That was something that, that I think the legislature wanted to be very clear on, that this wasn't, we weren't putting any a cost on the state, that it's still up to an individual physician whether or not they want to go through this express licensure process, but the cost of us being a part of the compact will be borne by the physicians and the fees that would be otherwise paid to obtain those licenses. Yep.
So aside from enacting this into law, are there any next steps with FSA Media or anybody else before we could start having physicians use it?
Not that I'm aware of, other than, I mean, it's just us getting set up in terms of the regulatory process and the rulemaking process of the compact, so that physicians can start applying. The MQAC obviously will take the lead role in that. Micah Matthews, who is their legislative director, has spearheaded this effort for quite some time.
Any ballpark idea on when this might take place?
You know, I saw Micah this morning, and I should have asked that question to him, but I didn't. But I'll follow up with him and ask that. So I don't know, Representative Schmick, did you have anything you wanted to add on the compact?
I think that the one thing that's always been the sticking point in years past is that different levels of when there's a problem, different states have different levels. And if somebody in another state, maybe that doesn't rise, you know, where they don't even do an investigation or take action. In our state, that would be actionable, and that's been the real sticking point over the years, is the differing levels of when it does trigger an investigation or actions taken against that doctor. And that's kind of been the point for a number of years.
Any other telemedicine-related bills or issues that?
Well, my guess is at some point we'll have this conversation about the issue of parity, because Senator Becker did run a bill in the Senate on the question of reimbursement parity for acts of telemedicine, and it got complicated. The bill did not pass, but I think it started a conversation, and I think good points were made both by providers and by insurers, you know, on how this might impact the market. And I think it will lead to further discussion on that about what is the right or wrong policy for the state. And my guess is it'll be revisited potentially next year.
I was surprised to see that resurface, and I wasn't familiar with the process that bills automatically.
They're good for 2 years.
2 years.
Yeah.
Okay.
So they're still alive for next year.
Okay. So is there anything this group can do to help folks understand what the issues are on both sides? Or
well, I'll say this, and then again, Dr. Scott or Representative Schmick can tell me where I'm wrong or they disagree. I think there's not agreement on whether that's the right policy or not, Denny, from I think a couple different perspectives. So I think at some point I would recommend to the collaborative, even though I'm not a member of it, that, you know, it's a point worthy of further discussion. I don't think there isn't a group of people who know more about what the good and bad impacts of it potentially could be than this group, and so it's worth having further conversation about.
I had some conversations with the president of Teledoc at ATA because I wanted to understand their position.
I think that's.
I went and talked to Gary Capistran at ATA, and he clarified where their position is.
Yeah.
So I learned a lot by having those conversations, and now I understand what the biggest issue is.
It's going to be to the legislators. It comes down, is the value delivered and care delivered the same in that video conference encounter as it is at a face-to-face? And that's really what the question boils down to. And the majority of legislators have to agree that it's similar before parity will be imposed. And I'm sorry, I've got a evening commitment in Pasco.
Safe drive.
I wish we had a transporter for you, Representative Schmick.
Drive safe.
Thank you.
Sure.
Was it a broader thing that has implications on?
It's not. Yeah, it's not just defined to telehealth. I mean, it just has. You could be licensed and physically go. Thank you, sir. Good trip.
And so when it is ready to roll, will there be some announcement?
Oh, yeah.
And a how-to document?
I think the medical commission. Yeah, the medical commission is gonna roll it out pretty significantly. It's been a top priority of theirs for some time. So,
is there any way you could keep us in the loop or share any information that comes out so we can?
Absolutely. I mean, one thought or suggestion is we could invite Micah and his team to come
next time
to a collaborative meeting.
I think it's a great idea.
Okay.
We haven't set that for next time.
Right.
My vote would be we do it somewhere in the South Puget Sound, whether it's Olympia or Tacoma.
Yep.
To help.
The legislators might still be there.
Exactly, yeah. I think
I can
the
say
legislators
that.
would like that. I think it would make it easier for Micah.
Yeah, I think that's a, why don't we do that?
We'll either have to hit up multi-care or the legislators to have it where we did last time.
Okay.
When is our next meeting?
We haven't said it. I think part of it was thinking about when the session is out and how we would interface with them.
And let me give my 2 cents on that just so everyone knows. And of course, I'll tell you what I think is going to happen, and then the opposite will happen. Just being down in Olympia again this week, having been off for a few days, the kind of the conventional wisdom is that right now there are negotiators in the legislature trying to work out an agreement on the K through 12 funding issue, the McCleary issue. Because and again, this is speculation, but I think it's well founded. The idea being, until they come to a consensus agreement on how they're going to fund basic education going forward, it's hard to know what will be left over for the rest of the state budget. Define the box is how we talk about it. So if they get to that, once they get to that agreement, which, you know, they have significant differences between the House and the Senate about how they want to address that issue. But I know there's a small group of them working very hard on it. Once they get to that, then they'll have to move to the budget discussions. There is another state revenue forecast that is scheduled to come out June 20th. And that potentially could provide more revenue. It could not, which would make the budget negotiations more difficult. But if it provides more revenue, the thought is it could get the two sides closer together. And if that is so, if we wait till that date, the key date then to think about is July 1st, because if a budget is not in place by July 1st, there would be a government shutdown. Now, Washington State has never had a government shutdown. We've all seen it at the federal level. And the belief is the same, that essential government services would continue to be operated with emergency funding, but a lot of non-essential state employees would not be. I'm going to guess that means someone like Dr. Scott would stay working and I would not be considered essential, but we won't make it personal. I don't think anybody in the legislature wants to get to that point. So the belief is, much like 2015, where the budget was signed into law at 11:40 p.m. on June 30th, we would get to that point where a budget would be reached. Now, again, I say that, and they could announce next week they have a McCleary agreement, and they're going to start their budget and be done by May. So,
in terms of scheduling the next collaborative, do you recommend we try to shoot for sometime mid-June down in Olympia, or is that going to be too crazy? Or shoot for July?
we could try it, and then if they actually reach some type of agreement, it's unlikely that any of the legislators would be able to participate, because they'd be back in session down there, probably in all-day budget meetings. I hate to suggest that we wait until July. So
we'll tentatively look for dates in mid-June in Olympia, with hoping to have Micah Matthews there.
Okay.
And I'll reach out to Senator Becker's staff to see if we can get that same room as last time.
That'd be great.
That was great.
Probably the only reason we couldn't get that room is if they're in there actually negotiating the budget.
Business, yeah.
So, exactly. So no, but I think that's a good plan, and then I think we might just want to be subject to change if in fact they're called back into session. Right now, there's very few legislators in Olympia. It's only a handful. The rest are back in their districts.
Okay, great. So we've got about 20 more minutes, and I wanted to do just a brief kind of sharing time because we had some telehealth meetings, some conferences. There was both the NRTRC meeting here in Seattle in the second week of April, and then the national meeting, the ATA meeting, which some of us went to. And I thought, since not everyone was able to go, that maybe people could share one or two things that they learned from the meeting. And then we do need to talk about a couple of members who are moving off the collaborative. We need to vote on replacements for them. So I want to make sure time with that. If it's okay with you, I'm going to start with some things that I learned about telemedicine in general. This first thing I want to do is share a screen. I went to a talk by Old Dominion University, and it was about telehealth etiquette. And they took health professional students, so medical students, nursing students, and they walked them through. They had them first do a standard visit without any training, then they trained them. So I guess the things that were kind of funny were at the bottom. Some of the negative things they were doing was eating or drinking during the telemedicine setting, laughing, and then looking down and they're writing. And so that the person didn't know that they were not paying attention to them. So some of these things were, you're like, you really shouldn't be eating in front of them, but people were too casual. So the point is that there are some good etiquette training sessions out there, not just this poster presentation. There is a good quick video from University of Arkansas. So they're a TRC, and they have a little thing on telehealth etiquette. If people are interested, just a 5-minute video. I'll share that. The other talk I went to, which was very, very valuable, was by a woman by the name of Nina Antonetti. So both Cara and I were there. She's kind of the maven on billing and coding. She had a 90-slide video or talk that I think we shared, and I thought it was very helpful. And Cara and I were even wondering if there was a way that we could get her out here to kind of give her, her view on coding and billing, because that's been a constant kind of area of confusion for a lot of us. So those are probably the two things I'd say that I took away from ATA. Cara, Denny, Francis, anything you guys want to share from those various conferences?
I would agree. If you could get Nina out here, she's a wealth of information for most everything.
Another way to link her in, where she gives a presentation remotely.
Yeah, great idea.
Use the technology.
Yeah.
I think that ATA is quite honestly at a tipping point and at a turning point. They branded themselves Telemedicine 2.0 this year, and they're really trying to figure out the next steps. And I think that's primarily because this technology and use is becoming so accepted and recognized by a lot of folks that you have a whole ton of new players in the field, and it's not just the technology folks, it's EMR folks, it's workflows, data analysis and collection. And there was probably more folks than I've ever seen, 4,600 participants there, a ton of vendor space that was occupied out there. And it almost seems like it was vendor heavy in that respect, even on the presentation side. But still, I saw a lot of good presentations. And when I went back to download some of them, I didn't realize how many there were. There's so many good things in there. But I also think that there's a focus on clinical practice guidelines still, making sure that we're doing this safe and effectively and cost effectively and things like that. So ATA has several new ones, stroke and primary care, I think, but those will continue to come, I think. And those are good tools for folks that are jumping into the space. So I think they still have good intentions and motivations.
Oh, I was just going to say, I agree. I think that the two themes that I took away were quality was a big one, and this is coming from the clinicians that are providing services. And it was interesting because I think now sort of the virtual urgent care model is kind of mainstream. And when you're listening to some of the presentations, like, well, we were there like years ago, so what else is new? So they're really coming forward with, and just as one example, and then there's of course, ER and ICU and all the other great programs that are out there, but they are becoming more sophisticated. They've got a lot more data, and they're really, I think, very quality driven. So quality was a big focus, and that was interesting. And then the other big elephant in the room is payment.
Yeah.
And so that's the other thing. I think that they're swirling around the payment issue, but no one's really except Nina is, but she's she's got her own perspective, and she's got the data. But I'm talking about how functionally programs that are being developed in communities are actually getting funded and paid for.
And those two things should be related. Quality
And they should be related.
There was a lot about value-based care.
Yeah, I had a lot of values, right?
And then Ted Kennedy's presentation was mind blowing. I just love that. It just reminded me we're here about healthcare, not shiny toys. You know, just kind of snaps you back.
It was not Ted Kennedy.
I mean, Patrick
Kennedy,
Kennedy.
yeah,
Sorry,
he's the representative.
son of Ted Kennedy.
I have to read from my notes. So sort of the big themes that I picked up were telehealth should be used to provide better access to care, but also to improve and optimize the efficiency of care. You know, how can we use telemedicine to better, more effectively use expensive doctor time? And how can we use it to support team-based care and continuity of care to improve workflows? And how can we use it to optimize the level of care by each level of provider? So, you know, echo models or consultative care where you're working, you know, the specialist is talking to the primary care doc to help that provider raise his level of care. And then there was some discussion about using the right technology and the most cost-effective technology for telemedicine. So is interactive video conferencing really necessary? Because it's a little bit more expensive technology-wise, but also workflow-wise. And can the same thing be done by a telephone consult with a sharing of images, or even an email e-consult or a telederm, yeah, things like that. And then just sort of general theme, sort of what Francis was saying, was a focus in addition to payment and quality, sort of that we just need more outcomes research and more ROI research so that we can build better business cases for implementation, and maybe for parity legislation too. That we have a lot of like satisfaction stuff, but we need more looking into, you know, how is this a cost-effective means of delivering care.
Anything from the Seattle meeting, the NRTRC? Who are the plenary speakers?
I have to turn my head back because I've been to 4 conferences in the last
So
week.
Nate Lockman was
Oh yeah,
there.
Nate Lockman.
He was one of them. And
Who's Nate Lockman?
he's an attorney with
Was he the guy down in
Orlando, Tampa. Mm-hmm. He was really good.
He has a blog.
Yeah, he does.
Helpful for those folks who don't
Yeah,
know.
he does.
Mhm.
Yeah. And then the main guy's in Portland.
The
And he
pink
wears a skirt.
socks
I know
guy.
that.
The pink socks guy.
In
That
pink
was-
socks, yeah, skirt and pink
Yeah.
socks. So it was his name.
Yeah.
again.
You remember his pink socks though?
Oh, yeah.
Pink socks with mustaches.
I had an extra pair of listeners.
His kilt.
Yeah.
Did you go, Freddie?
No, it was a separate session.
Okay. Good. Thanks
Yeah.
for folks sharing that. So a lot of the talks were people would share their slides, and you know, I think within this group it's probably okay to share the slides. I'm not gonna post those slides. But it's just for now. I'd say that's for reference for folks to see what's being promulgated from ETN. Okay, so we have about 10 minutes, and I wanted to let you know about some transitions of 2 members of the team. One, I think you heard about Mark Del Vaccaro, who is the Chief Medical Officer at Seattle Children's. He has asked that the newly appointed telemedicine director, which is Mark Lowe, and Mark is on this call, that he take his place. And just to kind of remind you how this collaborative was set up, it was by your affiliation. So there were a certain number of Republican legislators, certain number of Democratic. We wanted large hospital systems, we wanted small hospitals, we wanted payers, of course. So people had asked, does my membership on this collaborative stay with me? Like if I move to somewhere else, or does it stay with the institution? My understanding, and correct me if I'm wrong, Ian, because you were there, was that this is an institutional membership, so that it's okay for Seattle Children's to replace their representative. Is that
Yeah.
correct?
So way back at the if you all remember applying to be on the collaborative, that Senator Becker, Senator Cleveland, Representative Berquist, and Representative Schmick had come to a consensus of that they wanted different areas, different fields, different opinions, but we kind of broke it up by institution. And clearly Dr. Del Vaccaro his position is there to obviously represent the perspective from a children's healthcare provider perspective, and how telehealth can be advanced in the care for children. So I think it makes perfect sense, from my perspective, from watching the collaborative be formed in the legislation 3 years ago now, that it makes sense for institutional representation. And of course, I mean, whether you're talking children's or Mary Ridge, you're obviously talking about a particular form of care or institution that provides particular care to child patients. So it would make sense.
I'm wondering if we could have a motion to have Dr. Del Vaccaro replaced by Dr. Lowe. Second. Discussion.
Second.
Okay. Any discussion? Any concerns? Issues? Okay. All in favor?
Aye.
Aye. Anyone not in favor? Anyone in disagreement? Okay. We'll say that passed unanimously. The second person we need to talk about is Julie Stroud, who's at Multicare as a Multicare representative. She will be joining a clinic, the Northwest Physicians Clinic, and she has recommended a replacement. I would like to review the replacement CV since I don't know this person and I don't think any of you all know him. So if it's okay, I would ask that we get that person's CV and vote on it next time. Is that okay? Okay. I think it's Zelbani. It was a Z, began with a Z. Can you remember? Priscilla was in that email. So it was not anyone I remember, but it's basically the person replacing her. So same position. Yeah. So I think that's it for transitions on the collaborative, and I do want to open it up for public comment. If there's any questions or comment from the public, please identify yourself and where you're from. Thanks for chiming in. Anyone from on the phones, from the public who wanted to chime in?
Hi, Dr. Scott. This is Lisa Roach with Providence.
Hi, Lisa.
Hi. I just had a quick question. I caught that the first bill that was passed was SB 5436, and I had a question what the bill was for the Interstate Compact.
1337.
1337, Lisa.
Okay, great. And then I did want to let you know, I apologize, I didn't have that letter ready for you prior to this meeting regarding the letter for the to go out to the insurance companies. But I do have a rough draft of that, and I will update it with this new Senate bill and the new broader wording defining home and get that out to you.
Okay, thank you, Lisa.
Mm-hmm.
Anyone else? I see there was a chat, and I'm having problems pulling up what the chat question was. I think that was her.
Yeah, the chat was for me also asking for the Senate bill number regarding the new passed legislation.
Okay. Anyone else? Leslie or some other people are on the phone? Okay. The only item we didn't get to was an overview of resources for provider training that I kind of alluded to some of that. That's some stuff I have been working on, and hopefully we can get to that next time. So unless there's any other orders of business or
just a question related to that, can you tell me what you're thinking there and what the question is?
So if you recall, Denny, in Olympia, the meeting down in Olympia, there was some discussion about whether there should be training. I think that's still up for debate. My purpose of this is only to offer up if someone was going to do training. These are some of the things I would think is kind of my brainstorm, and I was only going to use it more as a brainstorming session. I'll just let you know we are going to be doing formal training for all of our UW providers so that we know that they are going to be in compliance and and there's going to be a QI component. That's just what we're doing internally. So I'm just going to kind of share where we are with that.
Are you thinking that would be a requirement to practice? Or?
I think that's still up for debate. This is
Okay.
only more of an educational, that if people wanted to do it internally, this is kind of a, an idea of a place to start. I think there was enough disagreement on that I didn't think there was ever going to be more discussion. Yeah.
So comment on that. At Swedish, we actually have modules that the providers have to go through. They're not super intensive, but some of that, the depth of that education is to go into the technology, the privacy, the confidentiality.
Etiquette.
Exactly.
Yeah.
And then we do face-to-face training.
I know, Francis, you've done guidelines, written guidelines in there too.
There's some of the ATA guidelines go over that. They go over etiquette, they go over some of the basics, and they cover it pretty thoroughly.
Okay. Well, I'm always hearing Senator Becker in my mind of how do we keep the doctors out of trouble? I mean, that's my main motivation, whether it gets codified or not. It's how do we keep them out of trouble and make sure that telemedicine doesn't get a bad name.
Yeah, we have a pretty in-depth training process at Karina, and it's actually kind of like a standalone product that we offer, and we license it out to a lot of the health systems that we work with too to train their providers. And it's obviously catered to the software that we use, but it's a pretty comprehensive educational program. Very creative.
Karina University.
Karina University.
Yeah. Yeah. That's great. Okay. Anything else? All right. Well, great. Thanks everyone for coming over to UW. We will be sending out a poll once we lock down a couple of times and locations, but I think we're trying to be in South Puget Sound next time, just so we can grab more of the legislators and hopefully like them as well. All right. Thanks.
Thanks.